Hello beautiful couples. Welcome to another session of Garbhankur pregnancy series. I welcome you all to the most important topic of this series is to deliver vaginally after cesarean section. This is the most common question asked to a doctor that I had a previous birth with cesarean section, so can I now deliver vaginally or normally? So today we will discuss about all the pros and cons and settings, why, how, what we can expect, all about vaginal birth after cesarean section, what is called as VBAC or TOLAC, trial of labor after cesarean section. There have been few issues in modern obstetrics now also that are controversial, and that this is one of the topic, cesarean versus normal delivery after a previous history of cesarean section. In 1916, Gregin gave a dictum that once a cesarean, always a cesarean, but that is not true. And this is proved with many studies and improvement in the surgical skills and expertise available, facilities available. So now we have better options, better facilities and better delivery options also. After a cesarean, patients are having so many of queries, so many of doubts in their minds that earlier they were planning for normal delivery, but somehow for some reasons they had to go for cesarean section. And now with the modern obstetrics and modern facilities available, many patients are opting for elective repeat cesarean section, what we called as voluntary cesarean section. So after cesarean section there are two options, either going for trial of labor or opting for elective repeat cesarean section. In 1921, Monro Kerr has devised a new technical skill, what we call as transverse uterine scar. That technique has improvised many things, that the previous surgical skills and the chances of having a vaginal birth and the complications associated with that are very less. They are very few, but we should know what are the complications and what are the magnitude of it, what is the severity if it happens. So there are many complications, like if there is a previous history of any uterine scar or any uterine surgery, then there are chances of uterine dehiscence, scar dehiscence or uterine scar rupture, or the morbidity associated with that, that is the blood transfusion, wound infections, or shifting from one hospital to another, or there are many neonatal complications also, hypoxic ischemic encephalopathy or even neonatal death. So in overall, maternal and perinatal morbidity as well as mortality can increase because of this scar. So it is very important. So you should know as you are pregnant, and you should know all the in and out. You should discuss with your doctor right from the beginning of your first prenatal visit. You should know what are your chances of getting a VBAC, or what are the high risk factors if you develop it in over a period of time during your 9 months journey. What should we do? Either we should go for elective repeat cesarean section voluntarily, or if I will try for labor, then what are the chances of delivering vaginally? So if you are trying for a trial of labor, and then your delivery chances of normal delivery, they are up to 80 to 83%. So in many studies it is seen that the chances of VBAC are 70 to 80%, as high as 70 to 80%. And if and the satisfaction rate is also much. If the patient undergoes a smooth vaginal delivery, the satisfaction rates are as high as 80%. But if there are some complications, or if the trial of labor doesn't fulfill and the patient need to take for cesarean, then the satisfaction rate drops down to up to 50%. So if the patient is opting for voluntary cesarean section, the satisfaction rates I have seen as high as 90%, because the patient is already informed, all the pros and cons are discussed with the patient, and the patient is voluntarily choosing cesarean section, because there are many patients now, because of the modern obstetrics and modern facilities available, the modern anesthetic skills and the post-operative care, that all have improved the post-op recovery period, and so the patients are opting for voluntary cesarean sections also. So we have to discuss with all the surgical risks and anesthetics risk with the patient, and after that, if the patient is ready to take all that, though they are very few risk, like it is very low complications associated with a voluntary cesarean, but still we have to discuss with them that these are the some risk: anesthetic risk, surgical risk, bladder bowel injury risk, or any postpartum hemorrhage, or blood transfusion risk, or any bladder injury. So these are all to be discussed. Before planning cesarean section, we see for the fetal maturity. That is the most important thing before planning. Nowadays many patients are having some or other day decided, so according to their auspicious occasions or muhurat. So we plan generally 38 to 39 weeks of at the age of 38 to 39 weeks of maturity, because the lungs are mature enough so that there will be no risk of any neonatal distress or admissions to the NICU care. So we have to be sure with the prior reports and medical history of the patient, depending on the sonography reports or fetal heart first documented on sonography, or the movements perceived. If the LMP is not known, there are many criteria by which we can calculate the dates exactly, and we can plan the cesarean after 39, like 38 to 39 weeks. And if we are planning before 39 weeks, then we have to go for the steroid injection shots, that is betamethasone or dexamethasone, whatever is available with you. Then we can give that for planning before 39 weeks, so that the lung maturity will be fair enough and the perinatal morbidity will be lessened. So what are the factors which are associated with increased chances of success for trial of labor, like VBAC? So if the Bishop score, that is the cervical ripening, is much, they are favorable, Bishop score is favorable, the cervix is dilated somewhat, favorable dilatation, then that patient can deliver vaginally early, and the chances are fair enough for going successful vaginal delivery. If there is only one previous scar, or if the patient is having a history of previous vaginal birth, then the success are very much high. Previous vaginal birth is the best predictor for success of VBAC. Maternal age less than 40 years of age, maternal BMI less than 30, the interdelivery interval of previous cesarean, if it is more than 18 months, or the Bishop score, favorable Bishop score, and the patient's fetal heart are very much reassuring. These are the some of the major indicators for having VBAC. Previous vaginal birth, normal vaginal birth is the major predictor for success of VBAC. Who is the ideal candidate for VBAC? As we have previously seen, as per the patient, the patient's factors we have seen. Along with that, we have to see the facilities which are available with you. If the number of previous scar is 1, and there is clinically adequate pelvis, and all the other factors which we have discussed, they are fitting the criteria for VBAC. The physician or the consultant obstetrician gynecologist is available there, and the anesthetic person is also available. 24 hours service, emergency services are available, blood transfusion services are available, the pediatric care or an ICU care is available. That you have to see all these facilities with you. If these facilities are not with you, or if there is any doubt of the healthcare provider that they are not able to give you assurance for all these facilities in emergency, then you should go for a better healthcare provider or a better healthcare hospital where these facilities are available, and the healthcare provider is very much easily doing all these facilities in their routine practice. So what are the factors which alter the risk of uterine scar rupture during VBAC? So there are many factors which are associated with increased chances of uterine scar dehiscence or scar rupture. We should take the detailed history regarding the previous number of surgeries done, if there is any other surgery done on uterine wall, like fibroid surgery or any hysteroscopic surgery which had led to perforation, or any other kind of surgeries which are giving scars on uterus, any anomalies of the uterine uterus like bicornate or unicornate uterus, then that also increase the risk of scar rupture. Then the number of cesarean sections, if the patient is having a previous number of cesarean section 1, 2 or 3, the chances increases exponentially with increase in number of cesarean sections. Then what was the type of uterine scar, in how many layers the uterine stitches were staged. Then the number of layers, and the healing, if there is any history of post-operative infection or fever in the previous surgery, endometritis, then the chances of poor healing are there, and the chances of increased risk of scar dehiscence in present pregnancy. So we should have the indication, what was the indication for previous surgery, is there any associated medical factors in present pregnancy also, and in previous pregnancies also, like increased risk of preeclampsia is there, if there is a history of previous pregnancy, in previous pregnancy if there is history of preeclampsia, then the chances of recurrence in present pregnancy, they are also increased. Then the maternal age, maternal BMI, the inter-delivery pregnancy interval, twins, or if there is any prolonged history of prolonged labor. So there are so many factors which have to be considered before getting to a point or getting to a decision of having a VBAC or elective repeat cesarean section. So all these points and the chances of having a uterine scar rupture or neonatal morbidity or mortality or antepartum stillbirth, is there any history of diabetes, is there any history of IUGR, is there any history of other fetal complications. So all these factors are to be comprehensively seen, and then the decision has to be taken, and it has to be a shared decision between a doctor and the patient, your healthcare provider and the doctor. The patient, or the information leaflets are also given. So this is a chart of comparing VBAC and elective repeat cesarean section. So all the points and all the checklist, this has to be scrolled down, and if there is any emerging any high risk other factor in present pregnancy, all these points are to be considered, and then the shared decision has to be taken by the healthcare provider and the patient. If the patient is induced with the oxytocin or prostaglandins or some injections, then the chances of previous scar rupture also increases. So we have to see for all the factors, all the cervical factors, Bishop score before inducing, and as we have already seen, that all to be discussed with the patient. So what to do when a patient is opting for VBAC and she is having labor pains? So as early as possible, she should contact her doctor or healthcare provider and get admitted to the hospital, because continuous fetal heart rate monitoring is the key for early diagnosis of any scar dehiscence or rupture. So if the fetal heart rate are reassuring, then we can continue with the VBAC trial, and if the fetal heart rate are not reassuring, or is there any tachycardia or decelerations, then we can the doctor can take the emergency cesarean section decision. Doctor, can we go for a painless labor during VBAC? This is also a commonly asked question. So yes, you can go for painless labor or epidural analgesia during VBAC, and that will help you to cope up with the labor pains, and it will not affect your chances of success of VBAC. So it will help you ease the labor pain, and it is not having any kind of adverse effect or any effect on the fetal heart rate pattern or the chances of your successful VBAC. What is this placenta accreta or increta? this is also a common query because the patients have heard something or another thing from their relatives or another doctor. So if the scar is there and the placenta it implants on that scar, the chances of adherent placenta or accreta, they are increased. So we have to counsel the patient in counseling session only, inform the pros and cons of having a elective cesarean section. So in future she can have this complication, but it is very less, so we can give the estimate like it is very less, and 0.5% of scar rupture incidence is there. So as we have already discussed, we have to see a comprehensive overview of the patient and her condition for deciding the mode of delivery. I hope I have answered all your questions, and if there are any other questions related to this topic, we can cover all that questions in our live sessions, in Ask Me Anything sessions. So tune into this, and we will also guide you accordingly, and we will update you whenever we have the live sessions. Thank you.